Today I'm very happy to welcome Professor Arieh Shalev from Hadassah. Professor Shalev got his MD from at the University of Montpellier and then completed his residency in psychiatry. He until recently was the head of the Department of Psychiatry at Hadassah. And in addition, Professor Shalev is the founder and the director of the Center for Study of Traumatic Stress. His research focuses on consequences and mechanisms of psychologically traumatic events, and today we will talk about PTSD from bedside to bed.
Many thanks for the introduction. Thanks for having me here. Well, having heard what level of prices this department is getting, it's just humbling me, and I'm trembling and shaking because coming to present to you, I thought that I shouldn't pretend to be a would-be neuroscientist or someone who has any understanding in that, but I would rather present a topic from a clinical perspective, from a purely clinical perspective, with the hope that eventually a more rigorous description or a more detailed description of the phenotype will provide those who are in neuroscientists with better hypotheses to look into. So I'm really going to present from bedside to bed, which is the opposite of what people usually do, and share with you some insights that are related to post-traumatic stress disorder, which is basically a phenotype that has been researched and invested many years. Our center at Hadassah started its existence after the past 4 or 5 incident in 1989, where we had 16 survivors evacuated to Hadassah, and we thought, why wouldn't we collect some data along with doing early intervention? And that led us first to understand how easy it is to ask people in a systematic way how they are, how willing they are to respond, and what kind of complex picture you discover when you really ask people about how they are. Supposedly, assuming that these were animals in a box, and you turn the box 3 times into a valley, you will have somewhat of a uniform response. Whereas when we dealt with humans, some had were extremely distressed just because what they saw in others. For example, a woman who managed to rescue her nephew from the rubble, as she were, and where she was quite happy with what happened, and she was going this is the best. I had shown myself that even under the worst circumstances, I function in a very organized way, so that the entire stress exposure is mediated by cognition and by perception to a degree that struck us as something that is worth looking into, and this is basically what we've been doing since. Along the years, we looked into in this paradigm of prospective studies, looking at survivors as soon as they arrive to an emergency room, to Hadassah emergency room, following them for weeks and months and years, and look at different levels or different layers of their response to a traumatic event and how they develop over time. We described the fact that higher heart rate in the emergency room predicts PTSD or is associated with the occurrence of chronic PTSD, and this has been replicated about 10 times since. We could show that in contrast, the abnormal startle response that you can see in chronic PTSD does not exist within a week of a traumatic event, and progressively develops or incubates within the 4 months after trauma, at which time they have exactly the abnormal or the biased startle response that you see in chronic PTSD. So something happens in this. We thought we were looking into a window of opportunity where something changes within the CNS such that these elementary noises, pure noises, are being treated in a very different way 4 months after expressing PTSD symptoms. This has been corroborated by a twin study from Vietnam showing that the abnormal start was actually related to being in combat and developing PTSD. It didn't exist in people who were in combat and did not develop PTSD. We unfortunately found that benzodiazepines administered days after the traumatic event, as many people do, many physicians provide benzodiazepine to patients, increase the likelihood of remaining with PTSD symptoms 4 and 6 months down the line, as if they interfere with the recovery. And this has been also corroborated by an animal study, Matar and Hagit Cohen. We thought that it might be a problem of timing. When you provide benzodiazepines at the time where the most of people have to do is to learn extinction, you interfere with the acquisition of extinction. But this is a finding that has also been replicated a couple of times. We looked prospectively at the hippocampus, since there was data in the literature telling that the PTSD, post-traumatic stress disorder, was associated with smaller hippocampi. Actually, it is not specific. You do find that in schizophrenia and in depression, but we had a chance to look at it prospectively, and we found that the hippocampus doesn't shrink with time. We scanned people a week from the traumatic event, and then 6 months later, and then 3 years later. There's no change in the volume of the hippocampus in those who express and develop pre-PTSD. And eventually, a group from the Mass General came with a twin study showing that smaller hippocampus is a vulnerability factor, and shared by co-twins. So this is a vulnerability factor rather than the whole theory about stress being, doing damage to your hippocampus was corroborated. And we looked at the unstable association of peritraumatic dissociation PTSD. I'll show you data. This is something about how you can change entirely your results when you just change one of your measurements, one of your scales, and the entire result change. This is a set of studies that we've been involved. Most of them were negative studies, unfortunately, particularly the one that had to do with cortisol, looking at cortisol, ACTH, glucocorticoid levels in peripheral blood and saliva at the time of the trauma, and then following people over time, assuming that we might uncover a predictor, like low cortisol level was the word, lower than normal cortisol level. Why lower? Because presumably in the immediate stress response, cortisol would come as a terminator of the initial response. So lack of cortisol would enable a prolonged norepinephrine effect on the amygdala. But there was no difference, and this was a negative study. I think I'll relate to it. And in the last 4 years, we've been really looking into ways of preventing PTSD, which basically was a social effect. It started in the Intifada, at which time we were busy drawing blood, 18 tubes of blood for each and every patient we could get into. And my team said, why won't we do something for these people? And we have been engaged since a very large prevention study, which are mainly clinical studies. But I really don't want to go into that, because that would make me discuss the data that would be informative about my own work, but may not be informative about what you should be looking at when you think about studying PTSD, which I will come to from another perspective, which is a clinical perspective. So what I'll try to do is to outline clinical dimensions that might be relevant to basic research, clinical dimensions of the disorders that we call PTSD, and then to illustrate these dimensions by some of the data from our longitudinal study, and then eventually outline areas pertinent to basic and clinical research in the future. One issue is that many people think that they are building models, animal models, and others that are relevant to PTSD. So I won't really go into the PTSD in depth, so that to show you how complicated is the PTSD, the outcome of trauma. And since I decided to be very clinical, I will start by the edge by a psychotherapy. What you see in psychotherapy, I'm still working with psychotherapy, this has been published under the title Levels of Trauma many years ago. It's basically a description of 38-year-old female with full PTSD after multiple assaults. She was irritated, angry, avoiding and startling, and she came for therapy remembering an event that occurred at the age of 17, where she was molested by a man, and her parents were far away and couldn't come to rescue her. And this is a description of her molestation. It's really unimportant. But what you see here is that she reacts by very elevated heart rate level in our laboratory. She reacts to listening to a script describing her trauma by very, very high, very elevated heart rate response, going up 22 beats per minute within seconds of just making an image of that particular event, which was at the age of 17. She's 21 years ago. As soon as she starts thinking about it, there is that level of arousal, unlike other personal stressful event that occurred in her life and personal positive event. And this is across the literature of post-traumatic stress disorder. People with post-traumatic stress disorder, as soon as they are presented with reminders of the traumatic event, internal or external, meaning a sound or just a thought, react by that kind of arousal response. We thought that we could do some exposure therapy. What we decided to do was called reciprocal inhibition. This is the negative scenario, the traumatic scenario, with our heart rates, the heart rate track. And this is a very positive, the most positive moment of her life, where she felt in full mastery. And we were just getting her to we were trying to desensitize the traumatic response by alternating between the good and the bad.
It's within a session?
This is within a session. This is within a session. And you can see that within a session her heart rate falls down. This is a very elementary behavioral techniques, except that in the physiological laboratory we could record her heart rate. And eventually her symptoms improved. Symptoms related to that particular event improved dramatically. Except that this was not the end. And once she was free from really being flooded by memories of that particular traumatic event, she started to come with memory, with fragments of memory of something that happened at a very young age, at 3.5 years, I think, when she was abused by doctors. She had some remote memory, but progressively she started to bring memory, and this is important to hear how she described it. This is actually her writing the script that we would read to her in a psychophysiological laboratory. So this is the description of the event. You are in a doctor's office on the second floor. You feel a lot of pain in your butt. That's the reason why the doctor took her and was going to take care of her. You are on the examining table and see the examining table. Suddenly you become suspicious and realize that you are trapped in what is a definite evil without even knowing. You see a man's genital and feel your face pushed against his pubic hair, and let you read all that. And this is really a description of something horrible that happened at that particular age, which she didn't remember entirely, but in therapy, during treatment, she could remember it. Terrible event. You feel nausea and terror, and no is trying to come out, but there is nobody. He actually forced her into oral sex, and there's nobody to call for help. Okay. So we decided to desensitize that, because we knew something about desensitization, which went quite okay. And she was less symptomatic, but even worse in terms of her depression. And this is what she wrote to me. Therapy was not complete yet. While successive steps of desensitization, exploration, empathic mirroring, etc., they were not sufficient for complete resolution of her predicament. And all of a sudden she goes, as a child, and that's what she said, this woman has not simply been raped by a man, she'd been faced with evil. She consequently developed deeply entrenched defensive lifestyle in which one of the main themes was her determined commitment to fight evil, particularly evil caused by man. She was really very unhappy with that. And rediscovering depressed memory, actually this is her words, therefore could not answer her many questions about good and bad and about basic human faith. And the therapist was challenged to respond at another level, at an existential level. And there, as a Jew, the experience of surviving evil, this was something that I proposed to her. You know, we, as Jews, we know and we have survived. We survive evil. That's the essence. And in which case, honorable survival is, in some situations, all that we can expect from life. And to our mutual surprise, she really took the term honorable survivor and started to work in a way in which she could live with these memories without being bothered by them. And on the basis of her acceptance of the honorable survivor, she further gained insight into female vulnerability, and then reluctantly considered the possible existence of parallel male vulnerability. Finally, human vulnerability became the source. What I'm actually telling you is that when you see a patient with a trauma, that particular event goes through many layers of interpretation, of elaboration. And it is never the original conditioned response, or whatever. It is all wrapped by much higher level of human relatedness, so that the end product of a post-traumatic stress disorder person that you see is always complicated by issues related to human relationship and beliefs about life and expectation, expected reality, and sometimes these are these much higher level of elaboration of the original event that prevent people from moving forward and eventually doing the work that would be necessary to get rid of the very original response. So what are we talking about formally, now that you've tasted some of that through a description? The PTSD as a formal diagnosis includes statements about the traumatic event that you all know. You can look in the literature, and this is one of our troubles, because the literature, the formal literature, provides with very shallow description of a traumatic event. It was an event, and people reacted to it with helplessness, fear, and horror. Why is the classification like that? Because this is what you can get from people. This is what they can reliably communicate to you without you and them using higher abstractions to deal with the trauma. So it's more reliable than the other abstractions. But if you want to study PTSD, you may think about some alternatives. This is not a psychological description. This is a very formal, this is what can be communicated and understood very easily. Could be that the event was essentially unexpected, uncontrollable, and inescapable. You think about Seligman. If you want to build an animal model, you would build it on these elements. You will devise a condition where there is inescapable, unexpected, and uncontrollable stress. But we don't use that to define post-traumatic stress disorder in human. Maybe it is something totally different. Maybe it's the grotesqueness of the event. Maybe it's something that the event has to do with its being totally unacceptable and utterly incongruous with everything that people describe. A wonderful description of the Buffalo Creek flood, which was one of the first disasters to be studied by therapists. And there was the description goes like that some people, the flood went down a valley and houses were decimated, and some people, those who describe it, managed to escape to a higher ground. And basically, they've been through a stressful situation and they managed to escape. So they sit there and they are quite okay. They save themselves. And then they start to see fragments of houses and people standing on these fragments of houses. And then comes that horror. That's something that is totally incongruous with imagination. And the whole experience becomes something very different from the original simple stress exposure and resolution. maybe it is the grotesqueness of some event, and I will argue positively, that make them more amenable to create PTSD. So this is one dimension. The other symptom cluster is that the traumatic event is persistently re-experienced by recurrent recollection, dream, nightmares, acting and feeling as if the traumatic event was occurring. I sit with a young person who was hit by a stone, lost his eye in the Intifada, and he was in a jeep. And as he describes what happened to him, by the end of his description, he is like that. So his body is back into the situation. We are in a medical office, but he is just getting back physically into that without even feeling that he is reenacting an entirely bodily situation. So that's the kind of re-experiencing of the traumatic event. It is nothing like memories. These are not memories in retrospect. You don't remember, post-traumatic stress disorder patients don't remember things retrospectively, having happened to them. They remember them, they fall into them as soon as they start looking at them. So this is basically a re-experiencing, a full re-experiencing of the and you may want to think about it from a neurobiological perspective. Something is recruiting the entire consciousness into re-experiencing the event. There's no time and space tag attached to it. Okay. And physiological reaction. The other interesting feature of that is that it sends physiological reactivity to expose to internal and external cues. Had it been just external cues, we would be speaking about phobia. It would be enough not to expose yourself to elevators, and that is internal cues are memories, are thoughts, so that PTSD patients carry with them the cues that eventually repeat themselves endlessly, and they're trying to fend them off, which brings us to the avoidance. What do people avoid? Of course, they avoid thoughts, feeling, conversation associated with the trauma, activity, places, people, but they also avoid thoughts about the trauma. They try not to approach the kind of domain which requires quite a bit of effort. There's that effort not to re-experience, and they tell you, as soon as I try to relax, as soon as I close my eye, these memories come back. Inability to recall important aspects of the trauma, a very controversial criterion, but let me just put it like that. Post-traumatic stress disorder patients remember a fragment, and that particular memory fragment describes or represents the entire traumatic event. Eventually, they did not register the information as a whole picture, possibly a stress-related gun barrel vision. They just were conscious or obvious. But the event is not the event. They don't remember the event. The event fragment, a hand lying on the something that makes them remember the whole. So it's not even memory. And these three are quite interesting because they have nothing to do with avoidance. You can see a reason that avoidance is amenable to explanation by using the fear conditioning model. You are conditioned, you avoid. But these three are markedly diminished interest in participation of significant activities, feeling of detachment, restricted range of affect, sense of authority. This is depression. These are depressive symptoms. And eventually, since you need 3 out of 7 symptoms, it is eventually impossible to diagnose a patient with PTSD unless that particular patient has some depressive symptoms. So it doesn't stand alone as a disorder, which is again a twist of classification. But basically, when you study a PTSD patient, you are studying something that is in between the conditioned response and the depressive and something more generalized, or a numbing response. Okay, and the symptoms of increased arousal, which is basically to say that the patient is at any given moment expecting harm. When in the Intifada we tried to do behavioral therapy with PTSD patients, and one of the things that you do in cognitive behavioral therapy, you send people to the site of the trauma. You send people who are afraid of driving, you try to drive their cars. But we couldn't send them to Central Jerusalem because during the Intifada, everyone avoided Jaffa Street and Strauss Street, so we couldn't do that. So we had to move into some cognitive elaboration. And what we discovered by doing the cognitive elaboration is that when me or other non-post-traumatic stress people who are don't have PTSD go to Central Town, they have a relativistic perception. The likelihood of being hit is such, but if I'm vigilant, if I see that the shopping mall is well guarded, and if I only spend 15 minutes, I can negotiate. When you speak about post-traumatic stress disorder, is entirely, there's no probability, it's not probabilistic thinking. It's a one and all. It is sure that the next thing that will happen to me. It's all of none kind of compensation. And eventually you think about it, that these people are expecting harm at any given moment of their life, hence they're hypervigilant. They behave as if something can happen. Speaking just of that patient that I described, she couldn't sit in my office unless she had free way to the door. If I were between, or something was between her and the door, she was extremely distressed. That is the kind of hypervigilance, which is basically perceiving yourself in the midst of the situation for years. It doesn't change. Okay. So, right. So that I think should give you a view of how complex is the condition as technically diagnosed. What different dimensions are put together into that condition. Obviously, the first reaction, the first trend in the literature is to explain post-traumatic stress disorder as a conditioned fear response. People have been in a fearful situation, they were conditioned, now they hear a siren and they jump. It's a conditioned response. And eventually, yes, of course, if you expose post-traumatic stress disorder, this in our laboratory, to images, to mental images of the traumatic event, their heart rate, skin conduction, and the EMG frontalis, they're much higher than those of controls. Controls meaning soldiers who have been to combat and did not develop PTSD, accident survivors who did not develop PTSD. Then it would be a conditioned response because you get it very quickly and immediately. And I will argue that this is maybe a necessary, or even not a necessary, but not sufficient. I will show you data showing that the condition doesn't explain. Well, think about the horror element. This is fear. This is the 9/11. These people here are afraid, so they can have a conditioned fear response. Okay. What about that person? Is she afraid? Is she exhausted? Is she overwhelmed by experience? There's no fear here. That reaction is clearly not a fear reaction to the traumatic event. It's something different. And what will you think about these iconic pictures of the kids? Are they afraid, or they are just exposed to horror? That's what I'm trying to convey by the atrocity or by the incongruous experience. This is basically nothing to do with being afraid. It's being exposed to something that is totally incongruous with previous expectation, with anything that you know about. Yes?
Yeah, but this is at the time of the so-called event, which may be over a long time.
Yes.
But maybe the conditioning happens later, so the fear happens later. Maybe you don't need fear at the point of the event, but you do need it later.
Or maybe you don't need fear at all.
Not, but
maybe you need fear.
At the point of the event, the point in time, maybe you don't need fear at that point.
Yeah, but if you reason in terms of conditioned response, saying that there was a high UCR at the time of the trauma, and you see this reaction, you think whether this is enough, whether this is a good enough descriptor, and whether Alex get into some data on trying to mitigate fear or to mitigate stress response, and I'll show you that this is really doesn't really work. So there are other event-related modulators which are grotesque. Look at these three pictures. This is a man caught in fire in evacuation of a lager in a concentration camp. This is one of the images of people who jumped from the Twin Towers, 9/11. And this is obviously the officer in Vietnam killing another officer. You look at that long enough and you remember it. And you have to process it. Actually, they stopped showing this picture on the US TV because they thought that kids were overwhelmed by that. But these children were not afraid. They were exposed. So these grotesque images, they're not really amenable to simple extinction. This is nothing that happens between the amygdala and the medial prefrontal lobe. Eventually, you cannot reason that way. They actually initiate a cycle of distressing recollections because you have to grapple with it. Something terrible happened to you, and then you think about it time and again and a third time. And this is a normal way to process incongruity or novelty, and it is not. It is possibly a bit more cortical than would suggest a pure fear conditioning model. You start to you process them repeatedly, i.e., you produce PTSD symptoms of intrusive recollections. The cluster of symptoms of intrusive recollection may have to do with the processing of novelty, and not with a fear conditioning response. And eventually, when these things happen to you, they alter your map of reality. So, if I just use these words, and I promise to be very unsystematic and just following words, map of reality. You can describe the entire symptom as a perverted map of reality, map of fear. So this is the map of Jerusalem, okay? The area of Jerusalem. You can recognize the city. When the Intifada started, we were afraid to go to East Jerusalem. If you went to East Jerusalem, you were vigilant, or you didn't go, right? And as it went, more of Jerusalem was affected. Nobody went into the old cities. Then the Frank Sinatra cafeteria happened, and people started avoiding that. And this is Jaffa Street. There were places whom you couldn't really get into without having some alarm, experiencing some. You could negotiate and so on and so forth. But when things are over, as soon as the hostility stopped, you go to Jaffa Street. You don't think about it again. So you have redressed your map of reality. The map of fear, that map of fear which exists, obviously in animals, is very plastic. Our friends who wouldn't come to Jerusalem from Tel Aviv because it was very stressful for them, and we lived in Jerusalem. Very flexible. But the principle, what holds us in the map of fear in the way Spencer and other studies, is to assume that you are in a safe place. Relative to the hostility, you are in a safe place. What happened with this particular person, that particular dog killer? This is a PTSD patient, okay? He continued to experience fear or experience his environment, his immediate environment, as threatening. And when things go away, these are our PTSD patients living in Jerusalem. Each of them lives in the epicenter of the next event. This is their expected reality. So something changed in the way you map your fear map. I mean, nobody will go to, South Bronx at night. Map of fear. We don't go there, okay? But where you are, it's just the opposite of fear of map, such that the reality is contaminated by fear. And this is a very frequent reaction of post-traumatic stress. So they are at home, safety, and the reality, the perceived reality is that something may happen in the next second. So you can reason, you can build a construct of the entire syndrome of PTSD as some perverted spatial recognition of fearful and non-fearful territory. It's just trying to steer some other thoughts beyond the fear conditioning model of PTSD. PTSD never comes alone. I said that just to make a point. The proportion of men and women with no other diagnosis when they have chronic PTSD here is very small. Most of those who express PTSD express other diagnoses, which tells you about our classification. Because the same would be true for panic disorder, the same would be true for social phobia. Most anxiety disorders they're not presented as a unit. One of the problems with the early treatment study for PTSD is people were looking for a pure PTSD. So they were excluding from these studies everyone who had depression and phobia and alcoholism, and you get these wonderful results that never replicate themselves in a normal condition, because this is what your population look like. And the comorbidity of disorders around PTSD starts very early. This is 5 months after trauma. This is from our laboratory. I think 228 survivors. 141 had nothing. Some of them had PTSD, 37 had PTSD, 30 had MDD, and other anxiety disorder. You can see the overlaps. And some people were eligible. What? I'm sorry?
What is MDD?
Major depression. These were depressed. These had some other anxiety disorder, obsessive compulsive, phobia, something else, PTSD. And you can see even 5 months of the trauma, this is a mixed bag. This is a mixed bag, and there is overlap. And eventually, those who have more of these symptoms are more likely to remain with chronic PTSD syndrome over time.
So these are symptoms or disorders that were there before or developed?
No.
It's all
Well, we don't know.
That's
We don't. They are expressed at 5 months after trauma. Much of them developed after the aftermath of trauma. These are not. Most of the major depressions were not people who came to the traumatic event as depressed. This is, but major depression could have happened years ago, and it's just reactivated a pattern of MDD. But just to show that this is from the beginning. It's not that you become depressed because you're sick so much time and then you become depressed about who you are and what you lost in life. It's there very early. Now, I think the other important point that I think I really wanted to share with you is the natural course of PTSD, because this can solve some of the issues that I raised before. How does it develop over time? Since we've been following people over time, there is an issue of nomenclature here. We call acute stress disorder a disorder that happens during the first month, then it becomes acute PTSD for 3 months, and then it becomes chronic PTSD. This is a nomenclature artifact. Don't even look at them, because the symptoms are the same. The same symptoms. They get different names. So basically people express from day 2, day 3, the same cluster of symptoms. And the time course, all the studies, this is from study of rape victims, 94% of them express the full syndrome, the full PTSD syndrome. They keep thinking about the trauma, they avoid their thoughts. 1 week after the traumatic event, at 3 months this decline, 9 months, then it gets to the 25-15% of them expressing PTSD, i.e. expressing PTSD symptoms initially is a frequent response, is a ubiquitous response.
95% of those that experience the trauma?
Yes, 95% of rape victims. This is in the case of rape. Other traumas, so let me show you some other traumatic events. This is the rape victim. These are assault victims. 65% express symptoms that would qualify for diagnosis of PTSD. When you look at 9 months, none of them remain with PTSD. That means that there's something about PTSD. This is in terms of prevalence and frequency. So the early symptoms may be a normal response. And eventually the syndrome might be explained by lack of recovery or a disorder of recovery. PTSD just maybe a disorder of recovery. And if you look, this is our first study, prospective study. 13 survivors developed PTSD, and 38 didn't have PTSD. Those who develop PTSD, this is a 6-month and an initial determination. You test them on PTSD symptom level, anxiety and depression level. They don't develop new symptoms. They remain with the same symptoms over time. Whereas those who recover from the traumatic event initially express somewhat less symptoms, but they do recover with time. Basically, the word is PTSD is a disorder of recovery. When you look at symptom trajectory, individual symptom trajectory, most of them do that. When you do, this is with Dan King, we tried to develop individual growth curves to have a function here or not that we could implement then to predict PTSD. So these are people, this is year follow-up. This is 1 week, 1 month, 6 months, 1 year, okay? Symptoms in individuals. And the PTSD, those with PTSD, except for one person here, and this replicates in those with PTSD, again, do not develop new symptoms. They just keep expressing the same initial reaction that would be rather normal or ubiquitous along.
So that one is an example of a delayed onset, what you call?
That would be an example of a delayed onset, either a delayed onset or what you see in people serving in combat zone. particularly American, are coming with that. I think that as long as you're on a survival mode, you don't express PTSD symptoms. We never see PTSD symptoms before people come to safety. Their expression has to do with some ability to reappraise. You know, as long as you survive, you're trying to survive, you optimize your outcome. Just a presentation from Japan after the tsunami. They don't use the construct of PTSD for 2 years because people are just into the survival. Okay, right? Okay. So just to make it an illustration, if this is our network of, you correct me if I'm wrong on that, episodic memories. These are memories, autobiographical memories. Okay, fire on the beach, a new child is born, going to work, a wedding. You know, there's one that was specifically censored by Hadassah, the Director General, but so I have to specify that this woman is wearing a bathing suit. But anyhow, we all have these memories. You know, we've been here, we've been there. We don't have to remember them. They are there. They are subject to forgetfulness, and they are basically can be accessed to some extent, but they don't provide themselves. And what happens after a traumatic event? During the first day, everything is covered by that experience. This is taken from one of the battles. And then, progressively, what happens with time is that the potentially traumatic memory is being processed to become part of our network of episodic autobiographical memories. It doesn't dominate our life. We can recall it eventually. We can go back to it, and we can forget it. Okay? What happens in the non-recovery, the 15% who do not recover, is that the initial event is there, and after 1 year, and 2 years, and 3 years, it is still there. Obviously, the details are lost. It's very schematic memory. It's a very schematic recollection. They cannot tell exactly what happened, and it's entirely emotional. You cannot access that particular memory with it being flagged with being alarmed. And there it remains for years, and that's the way it comes back and forth in nightmares. So that's what happened for the non-recovery. The non-recovery, or I'm adding to what I said before, is that the non-recovery may be related to a change in the nature of the recollections, such that they are not detailed, they are fragmented, they are entirely, they are easily linked with the expression of emotion. How many times do I have? How long do I have? A minute? 10 minutes. 10 minutes. Okay. So, let me just a word about how can we predict PTSD. I skipped the prediction of PTSD from early symptoms, and I will just summarize it in one word. If you want to predict who will develop PTSD based on early symptoms, you have a very sensitive, very non-specific predictor. The reason is that everyone expresses the symptoms, so they don't predict anything, and only a minority remains with them. So it's a sensitive, non-specific predictor. At this point in time, we do not have a rating scale capable of predicting PTSD from early symptoms. That would summarize. The heart rate study, which showed that PTSD patients here in white have higher heart rate in the emergency room, could have been used as a predictor, except that you can see that heart rate levels in red of those who developed PTSD and those who did not develop PTSD entirely overlap. So that, again, there is no way to predict from heart rate. And although it is specific, so the explanatory power of heart rate, you would say that it's much for a biological study if you can explain ER heart rate, explain 10% of the variance in the level of symptoms 6 months later. It's a lot, but for a clinician it's not enough. It's useless as a clinical predictor of anything. Okay, start response not here. So let me go to the right. So based on the heart rate response, my colleague Roger Pittman tried to terminate the acquisition of PTSD by administering propranolol early on. This is a beta blocker. It crosses the blood-brain barrier. It should downregulate the adrenergic surge. And these are his propranolol placebo people. He started 6 hours after the trauma in Mass General ER, placebo, and at 3 months at the level of PTSD symptoms is exactly the same. And there was some spontaneous recovery, but you still have quite a bit of PTSD. So blocking the initial adrenergic surge 6 hours after the trauma, there might be a window of opportunity, we're probably unaware of time, doesn't affect the outcome in terms of PTSD. But it does do something very interesting. This is a retake of the same study, by Rogers' group, published after getting more than $2 million in grants to produce his data. This is PTSD symptoms. This is the percentage of PTSD symptoms 3 months after the traumatic event in those who received propranolol, did not receive propranolol. You can see that it doesn't prevent PTSD. But what it does very nicely, if you do the mental imagery procedure and you get people to the laboratory and they listen to their script, their heart rate response and their skin conductance response, if they receive, are much lower. It is almost a double dissociation. You could provide some treatment that prevented the acquisition of a simple condition response, except that it didn't affect the prevalence and the severity of PTSD. And I think it's so elegant to see that you can do that with major results, and you really don't affect it. Some of that etiology of PTSD may have to do, again, with the atrocity, with the incongruity, with something else that happens at the level of processing a total novelty, the redundant process. And if I were to just to leave you with a message, don't build everything on a simple conditioning model of PTSD. The whole literature is about conditioning, extinction, interfere with extinction, and so on and so forth. I just put a caveat on that. Maybe there might be, we don't know, a window of opportunity to intervene, either pharmacologically or otherwise, which is before the first memory consolidation. People think about it as the first 6 hours. Maybe we just missed. You provide Valium, people become sicker because you interfere with their extinction. You provide propranolol, after 6 hours, nothing happens. Maybe the window of opportunity to do something is much earlier. And I think this is one of the very, very urgent topics to uncover. There's quite a bit of animal research coming from Mike Davis' laboratory that if you intervene within the first few hours or the first hour after a condition response is acquired, you not only eliminate the expressed response, but you really eliminate the reinstatement. It is as if the memory of the conditioning event does not exist. Maybe we have something like that to work on.
Intervention by what in that case?
Intervention by what? That's very, very, very intriguing. I'm actually thinking of many ways. Some people are very keen on using Valium, like me, which is others would swear by oxytocin. What the animal research brings you to think about is any non-toxic blood-brain barrier that interferes with protein synthesis. If you can interfere with protein synthesis very early on, that might be the case. Some people go for oxytocin. I think that it's an open field, but I think that we really need to define whether any intervention, and we are just...
but there's no electrical, in animals, electrical stimulation paradigms.
I don't know about that, no. Okay, so maybe too many ideas for one presentation. It's okay, I'll stop here and take questions. That's okay.
Yeah. I guess that there are many circumstances where a patient comes to emergency room and is immediately anesthetized and operated on.
Yeah.
So would this anesthesia affect the PTSD?
Yes. Well, there's a study on providing morphine to survivors, published in JAMA, Best Medical Journal, that if people were injured, those who received opiates in the emergency room were much better than those who did not receive opiates. And the reasoning was around the mu receptor and everything like that. And so, yes, indeed, if you do something. But, skeptical as we are, we looked into that in our own study, and what we found is that we had, quite a large number of survivors. 140 received opiates in the ER, and there's no difference between those who received opiates and did not receive opiates. In a way, we didn't replicate that. Maybe they weren't injured. But when we looked at other painkillers, when you provide survivors in the emergency room with painkillers, could be paracetamol, or opiates, the fact of reducing pain reduces the correlation. This is a correlation between pain level in the ER. People report pain level on this rule. It is correlated with PTSD down the line. If you provide any kind of painkiller in the ER, if you reduce the secondary stress related to being in the ER, you actually are able to eliminate the relationship between pain and PTSD. So I'm not sure that this is what has to read about the mu receptor and the opiate receptor, but just about reducing secondary stressors.
I was asking about anesthesia, because
yes.
It interfere with the formation of long-term memory.
Yes, could be. Yes, always complicated based. For many people in surgical department, the real stress will come after. When they have to go in other surgery, when they feel they have uncontrollable pain that they're unable to control, when something happens to a relative and they're still uncertain, trauma doesn't end with the moment of anesthesia, particularly if people are injured. So we don't have data on that, and it would be a very interesting question. If you can find a comparator, a group that would have been eligible for surgery and that wasn't performed, or performed without anesthesia, if you want, something like that. It's very difficult to get into that, because you get into many confounds that you're unable to control for in prospective studies.
But there seems to be a very simple correlate. You showed an increase in the heart rate.
Yes.
And there are pharmaceutical means to prevent an increase in heart rate.
Yes.
Did anyone try to do
Propranolol. It reduces heart rate.
Okay.
It reduces 1 to 20 to 60 to 40 even. If you're overdosing, doesn't do the work. Possibly, we have to reason in terms of timing.
It's an outcome and not a cause. That's what you're saying.
Could be, but we should reason in terms of timing. I think the creation, it's a sequential process. There are things that happen initially during the first few minutes, hours, and there are other processes that intervene later on in terms of reappraisal, reprocessing, and eventually other types of processes that intervene much later on. And pharmacological intervention should be well timed to the moment in which it can change. So I'm not saying that propranolol wouldn't work, but 6 hours after trauma it doesn't work. When you start it 6 hours after trauma, it doesn't work. Maybe it's just because we missed a window of opportunity to reduce the harm.
I have 2 questions. One is in regards to painkillers.
Two?
To painkillers.
Yes.
Maybe because of the definition of PTSD, that also comprises of symptoms of depression and disturbance of sleep. So maybe reducing pain reduces that part of the definition of PTSD, and maybe I don't know what the core PTSD symptoms are, but arguably, if you reduce the pain, you reduce the symptoms that have to do more with depression and sleep disturbance than with maybe the flashbacks, and so that's one thing.
But this is reducing pain in the emergency room before PTSD symptoms even develop.
So that's the second question is, you talked about the small time window of memory consolidation.
Eventually, we
but
don't
then
know.
what about the small time window after reconsolidation? Or
Right.
not reconsolidation?
Right. There's quite a bit done at this point in time using the reconsolidation paradigm with D-cycloserine, with transcranial magnetic stimulation, enhancing the frontal or stimulation of frontal, and there's quite a bit, or with propranolol, such that if you evoke memories and then do something such that they cannot be re-encoded as would be required, and this is just very experimental, and that should work in chronic PTSD. I mean, there are molecules that are wonderful candidates for forgetfulness. This is a trend that we are just beginning to think about in terms of treatment. Right. Would be.
It could also be combined with cognitive therapy, with exposure, or with
Yes.
anything else.
The study is coming out with D-cycloserine, which is an enhancement of cognitive behavioral therapy. Apparently, it works quite nicely. Sure.
One possible, caveat of going from the bedside to the bench, I guess, is the fact that PTSD doesn't come in one flavor, but it is complicated, as you said, by anxiety and depression and stuff like that. But if you analyze, for example, the blood or any other tissue of those patients for early reacting genes or late reacting genes as a function of time, would you find any common denominator between different patients that would raise your curiosity as to some...
I skipped the gene expression study that we did in the emergency room.
Can you give us the bottom line?
Yeah.
Bottom line, the bottom line was that unsupervised clustering differentiated quite nicely in those who developed PTSD later on or not. And then
at what time this was done?
This is the entire sample from ER. We drew blood in the emergency room, but also at 4 months. If you look at the 4 months, we're really looking for a signature, not for for an underlying explanation or for discovery. If you use the clustering at 4 months, it's almost a perfect clustering, looking at differential gene expression. And the differentiating gene, which is an old study, was published in 2005. I'm not sure that the Affymetrix chip was well annotated at that point in time, and we haven't replicated it. Shame on us. So you see some of the families of genes differentially expressed that relate
all over the place.
All over the place, and you wonder whether it would replicate itself in an independent sample, whether something will remain. I mean, yes, some of the FKB5 has been identified and worked on, but this is really a fishing expedition, and the goal was to basically to see whether there is a signature that differentiates one from the other. Should be re-implemented in much larger sample and using much better molecular technology. So
you want to say that nobody else attempted to do this type of studies using very big cohorts of patients? The long one.
No, nobody else did that, because people go for single genes, people go for candidate genes, people go for candidate polymorphisms, and people think. I know. And you should move from that. If you want to look at the DNA methylation, differential DNA, there's quite a way of thinking about it in terms of high throughput methods. Except that it's not been done yet. I don't know whether it will be. I'm such a non-expert on that most people who I'm consulting, the medicals, who told me that don't go for that. It's so fuzzy, and your model will determine anything. That you're just model dependent, and you may not recover anything. But no, it has not been replicated. Probably we just have the chutzpah to do it, but no one else is going after. Ronen Segman from Scopus was the lead scientist. Yeah. Okay. Which reminds me to show you the ultimate. No, I don't have a picture of the gang. Okay. Please.
I don't know if this should be the last question, but did you ever get identical twins in the ER?
No. Identical twins. there's quite a large set of studies on identical twins with PTSD, unfortunately with chronic PTSD from the Vietnam Twin Registry. And these are these studies that show that that the hippocampus is similarly smaller in identical twins of survivors of Vietnam veterans who developed PTSD. In that sense, the number of studies of identical twins showing whatever you can show it with a cross-section approach to PTSD, we don't have that in an emergency room. And that's interesting. But next time we have identical twins in the ER, I'll jump on that and see what I can do with it. Thank you.
Michael, thank you very much. Let's thank you again.